Wishing you all the best as far as your continued work, and I'm excited to sit and listen in on today's discussion.
Thank you, Bridget. Okay, we are now recording. Let's see. Okay, hello everyone, and welcome to our Tuesday webinar series focused on implementation of the strategy of the Specialty Care Initiative strategy clusters. Today's webinar discussion is on increasing primary care provider capacity. As Bridget said, this is Louisa Miranda, Senior Program Associate with the Technical Assistance Provider Team from Community Partners for the Specialty Care Initiative. And as Bridget mentioned, I will be facilitating today's program. Once again, I would like to just have you look at our standing agenda for today. And just a reminder that after the webinar, we will be sending out all participants a brief survey to get your feedback and suggestions for these sessions. And we thank you all for responding. Okay, let me just move on to today's program. Sorry, just working out a few technical glitches here. Thank you.
Now, is everyone seeing that presentation slide?
Yes.
Yes.
Sure.
Okay. What I'd like to do is, as you remember, if you were on the call last week, in an effort to save time, rather than just calling out the names of the coalitions, we're just going to look at those of you who have listed on the participant list today if you're on WebEx, and we'll just go over the names and the coalitions. So we will begin our roll call. Okay, Amy Ham with YOLO, I believe.
Hi. Yes. Teacher for Safety Net, Yolo County.
Thank you. Brandon?
Hi, Valley Care Community Consortium.
Hi, Brandon. Thank you. Carla Alexander? Carla? Okay. Christina Wildlake, one of our Kaiser funders from Northern California. Hello, Christina.
Hi.
David O'Neill, our other funder from our California Healthcare Foundation. Hello, Dave.
Hello.
Diana Casey from Ventura. Haley Oval from Long Beach. Jerry Royer. Jerry, can you tell us who you representing?
Second.
Who are you representing today?
San Joaquin.
Great, thank you. Doug Howard. And you're with, please, Doug? Okay. Joel Derringer.
Yeah, with the Fresno HCAP program.
Hello, Joel. Joseph Sexton.
Santa Clara County Specialty Care Initiative.
Great, thank you, Joel. Joni Novosel.
Valley Care Community Consortium, Coalition for Safety Net Access Providers.
Thank you, Joni. Karen Leeds.
Yes, I'm with the San Francisco Specialty Care Coalition.
Thank you. Kimberly Dixon, our presenter today. Hi, Kim.
Hello. Excel Access El Dorado.
Lynn Farrell.
Council Community Clinic, San Diego.
Thank you, Lynn. Dr. Maria Chandler.
Hi, from the Children's Clinic and the Long Beach Coalition.
Hi, welcome, Dr. Chandler.
Thank you.
Nina Vaccaro.
Hi, with the South LA Collaborative for Specialty Care Access.
Thank you, Nina. Norma Forbes.
Hi, Fresno Healthy Community Access Partners.
Hi, Norma.
Hi.
And Sarah Shear.
Hi, with the Community Clinic Consortium in Richmond.
Thank you, Sarah. Have I missed anyone on the line?
This is Lauren Rodano from the Council of Community Clinics in San Diego.
Hi, Lauren. Anyone else?
Carla Alexander, Health Alliance of Northern California.
Hi, Carla. Thank you. Okay. Well, also just a quick reminder to please turn off your cell phones and mute your telephones to prevent outside disturbances during the discussion, and please do not place the call on hold. You can also mute by highlighting your name on the WebEx. And lastly, our webinars, as always, will be placed on CCV for future playback. Now we'll get started with our featured topic on increasing primary care provider capacity. For those of you who participated last week, you'll recall that our discussion on building and expanding specialty networks was led by two coalition project managers, Diane Emler from Marin and Lauren Rodano from San Diego. Diane and Lauren did a great job of sharing their strategies for recruiting specialists. And today we have Kim Dixon, who's the Care Pathway Manager from our Excel Coalition, located in Northern California's El Dorado County, which is in the Central Valley, about 40 miles east of Sacramento on the way to Lake Tahoe. The Excel Coalition is one of California Healthcare Foundation's grantees in the Specialty Care Initiative. So hello, Kim, and thank you again for agreeing to talk to us today about your approach to increasing primary care provider capacity.
Well, thank you.
Okay, and Kim, in last week's webinar, we used a conversational approach with coalition leaders, reviewing a list of questions to provide a forum for sharing best practices and learning, and feedback from participants was very positive, and everyone recommended that we continue using the same technique. So, for today, I would like to begin with our first question for you, Kim.
Okay.
Okay. I know that when we talked before to prepare for today, you mentioned that your group had been meeting prior to the Specialty Care Initiative. So can you just provide a little history and background of your safety net provider group prior to the Specialty Care Initiative?
Certainly. We have had a group meeting called our Provider Capacity Group that's been meeting for nearly 7 years, and it's made up of the primary care providers who reach the safety net population in our county. And through that group, we've created several care pathways already that have been focused on access to care for children. The group was started with our Board of Supervisors recognized the need when the tobacco settlement funds came in to address some of the health disparities in our county, and children was one of the issues. We'd also been looking at specialty care access, but hadn't tackled it yet because of funding, and just our focus hadn't quite gotten there yet.
I see. So let's just move on then to today. With your engagement in the Specialty Care Initiative, what has been your coalition's approach to increasing primary care provider capacity then? What changed?
Well, when the grant came along for the Specialty Care Initiative, it was a perfect fit for us because we had been talking about how are we going to go forward with specialty care. And the county had already identified that pain management was a huge issue. We have one provider in the county, and he doesn't accept any of our safety net population. And so we had gone forward with the planning grant and looking at what can we do to expand into the specialty care area. What our coalition did then, or our provider capacity group, was they pulled together a lot of the, or specialists from a lot of different specialties. So we had OB-GYN, we had orthopedics, we had neurology, a few others that came to one of our meetings. And at that meeting, they just kind of started talking about the fears of the specialists. The primary care providers started talking about their issues as well for getting patients into specialty care. And it was like the blinders came off of both sides of some prejudices that were based on ill-founded data. The specialists were afraid they would end up becoming the medical home of patients that they only wanted to do a consult on. and the primary care providers had felt like their referrals for their safety net population were getting denied. They started to understand why that was happening, and it was kind of a fun moment.
I bet. Can anyone in the audience relate to any of the discussions and some of the group meetings they've had with their specialists? Any comments from our group or questions to Kim on how things are at the beginning stages of conversations with their specialists, between the specialists and PCPs? Okay. Well,
I think there's someone that's very, very faint I can hear in the background.
I do too. Okay. Sorry. Well, hello?
Hello.
Okay. Speak up, please. Who's speaking?
This is Alan with Westside Neighborhood Clinic.
I'm sorry.
The connection is weak. We need to at least have you type it in the chat or get a more stable audio connection.
Can you hear me now?
Yes, much better. Thank you.
Okay, great.
Who's speaking, please?
Hi, this is Alan with Westside Neighborhood Clinic.
Hello, Alan. And you had a comment?
Yes, I just, when we started this was some time ago, and we just began working with the cardiologist, Dr. French over at Harvard UCLA.
Mm-hmm.
And it was, I remember just a particular instance where we had a patient who had an abnormal EKG, and we called Dr. French, and actually my provider called Dr. French, spoke with him personally, and faxed over the EKG, and he made arrangements on the spot to be prepared to meet the patient at the emergency room. So it took about 2.5 or 3 hours from that patient to get from, for initial visit here at our clinic in Long Beach, and 3 hours later she was seeing a specialist. And it was just, I just wanted to comment that pretty remarkable.
Well, the power of the champion.
No kidding, huh?
We'll be talking more about that as we proceed. Anyone else? Great. Thank you. Thank you for sharing.
You're welcome.
Okay. Kim, can you please tell us more about the primary care provider training and continuing medical education, or CME, program that you have developed as a result of the conversations that started between your PCPs and specialists?
Sure. So in those, the initial meeting we had, it was basically a wake-up call to the primary care providers that they had been making assumptions about specialty care that were not necessarily accurate, and that they should include in their monthly provider capacity group meetings specialists so they can get the specialist input. We had thought we would go forward with pain management as our first intervention, but we with the research that we did through the California Healthcare Foundation, we found that actually orthopedics was our highest number. That's where our greatest number of referrals were going. And right at the time of the grant, Medi-Cal cut reimbursements for specialty care, and the orthopedic practice, which is the only one we have on the Western Slope, cut access to any Medi-Cal patient unless they came through the ER. So patients are being referred by our primary care physicians 2-3 hours away and getting turned away on principle because UC San Francisco, UC Davis, Sutter Health, nobody wanted to be the dumping grounds for our Medi-Cal population. So we decided at the provider capacity group that actually we should go forward with orthopedics and seeing if we can open up access to care there. And part of the issue from the orthopedic perspective was, why are you sending me these patients that you haven't even tried aspirin with first? And what was coming out of the primary care physicians was, we did medical school years ago. We had just a small amount of time covering orthopedics. We feel like we're doing a disservice to our patients trying to give them any type of orthopedic workup even before we send them on to to a specialist. So that opened up the conversation of, okay, well then what is the information that the primary care provider needs to know? What kind of evaluations do they need to know, and what do they need to know to refer, and what do we expect of them to do before they refer, that from a specialist point of view? And from the primary care point of view, that any information along that line was completely welcome. They wanted to know, they wanted to be able to get their patients into specialty care, but they wanted to be able to do it appropriately. So when we looked at that, we were able to set up a clinic that was kind of a win-win for our patients through the tribal health clinic. And the orthopedic surgeons were able to get a decent reimbursement when they rotated through there. So we opened up access, but the other end of it was increasing the capacity of the primary care providers. And we decided to go forward with CMEs on the topics of how to evaluate and when to refer. And we did it anatomically, one on the knee, one CME on the shoulder, and one CME on the hand, wrist, and elbow.
Okay, when were those conducted?
So we did the first one, the knee, how to evaluate and when to refer, in the beginning of October, October 8th. We did the second one on the shoulder, November 3rd. And then we did the third one on hand, wrist, and elbow, February 8th.
Great. So you just recently had one.
Mm-hmm.
Can you tell us about the CMEs? How has that come about? Because I know some of our participants are thinking about doing that with their training programs. Can you tell us more about how you developed the curriculum, getting the credit for the CME?
Yeah. So, we didn't want to recreate the wheel and try and figure out how you do all the CMEs when within our county there's already systems for CME credit. The hospitals put on CME classes for their physicians, both in South Lake Tahoe at Barton Hospital and at Marshall Hospital. So with our physician champions, with our provider capacity group, they're very well respected in the county. Everything they do is the best interest of the patient, and if they ask someone to do something, most people will bend over backwards to do it. So our physician champion on our western slope approached one of his colleagues that oversees CMEs at Marshall Hospital and just said, through the California Healthcare Foundation, we're trying to improve access to care for orthopedics, and we're also trying to improve the primary care providers' capacity in dealing with orthopedics. So we will be putting on a series of CMEs on the topic. Could we do it under your umbrella? And they said, yes, of course. There's a few requirements that we ask of you, and those requirements were very similar to what we would want to do anyway. Sign-in sheets, create a curriculum, and an evaluation of the CME at the end. So right now the CME credits are pending but expected to come through for each one of the classes that we did have. And the curriculum, basically we allowed the specialists to develop. Through the provider capacity group and the discussions, it was already very clear, okay, these are the anatomies that the primary care provider needs to know about, the knee, the shoulder, and the hand, wrist, and elbow. They need to know about imaging, what images are and are not needed when you refer a client with medical approval processes for some of the imaging can take a really long time. So what is necessary and what's not necessary for the best interest of the patient. And what kind of evaluation tests can we do ourselves? Can you teach us to do before we send that referral? So with those guidelines, each specialist created their own very detailed PowerPoint presentation that they taught from when they did their CME, but it was also a useful handout that we photocopied and made sure everyone had, both in Tahoe and on the western slope. And it's something that they can take back to their clinics and refer to and use straight off of that PowerPoint presentation when they're doing their evaluation.
Great. Are there any questions for Kim? about the program or the curriculum?
I just posted one.
Great.
Yeah, I'll read it. We found that in order to get CME approved in advance for a presentation, we must get the application in many months in advance, which is difficult, and we go without in some cases. Now, with our CMEs, like I said, the CME credits are pending through the physician that oversees the CMEs through our hospital. He said, if you turn in the evaluation forms, the curriculum, and the sign-in sheets, we will, in all likelihood, be able to get you credits for these CMEs. So we did give the classes with the statement of CMEs are pending for these. So they didn't go in already with an approved CME credit.
Hey, Kim, it's Bridget Cole.
Mm-hmm.
Question for you. How were the sessions evaluated then? I mean, what was the response of your PCPs who attended?
It was, we had some very generic questions that we used from the hospital CME evaluation that we tailored to the specialty care, so for orthopedics. And the overall response was very high on a scale of 0 to 5. I think all but 1 or 2 responses were 4 or 5. Our greatest difficulty was we were using teleconferencing between both slopes, and so we had some technical difficulties, and most of our lower scores came from the technical difficulties.
So it was all teleconference, or were some folks in attendance and other folks via video?
Exactly. So we held one on the western slope where people were in attendance, and it was teleconference to South Lake Tahoe where people were in attendance in a room there watching it. And the second one was in Tahoe where those same people got to watch it live, and it was then broadcast to Placerville. And the third one was in Placerville back up to Tahoe.
Got it. And then the faculty then were specialists that were part of your capacity group or ones you recruited?
They were ones we recruited. The key one, he's one that we asked to come to the provider capacity groups early on. He was at that first meeting where we put all the specialists and primary care providers in the room, and kind of all these stereotypes just fell away as they talked. And at that point, he then went and talked to one of his colleagues and said, would you be interested in this and doing a CME on it? And he said, oh, definitely. And then we had good buy-in in Tahoe, too. We wanted to represent. Our county is kind of bifurcated by the mountains, so we feel very separate, but we wanted to include both sides. So the Tahoe side said, yeah, we have a doctor. Now, the key here is actually all of these physicians that presented are young, new doctors to the area. So for them, it's almost free advertising. They are getting out there, talking to all the primary care providers who not only have the safety net population, but they also have well-insured patients. So they want their referrals to be coming in from those doctors, and it's a nice way to get out there, do a community service, and get to be known.
Excellent. Thanks.
Thank you. Any other comments or questions for Kim on that?
Hi, this is Sarah from the Community Clinic Consortium, and I was wondering how long were each of your CME sessions?
They're about an hour and a half. We schedule them to be an hour and a half to 2 hours, and the actual presentation is an hour, and then we ask the specialist to stay around for an extra half an hour to answer questions, and a lot of the people want to see the physical exams again or practice, and so the specialist will stay and help them learn how to do those.
Great, thanks.
Mm-hmm.
Any other questions?
Hi, this is Dr. Royer. I have a comment.
Yes, sir.
I'm Chief Medical Officer at San Joaquin General Hospital and a member of the San Joaquin County Specialty Care Access Coalition. We have done a similar thing with dermatology, one of the 2 specialties we've addressed. And although initially we thought this would be primarily a teledermatology process, that it turns out, and we're doing that also, but it turns out we have a family medicine person who has a background and some skills in dermatology, and he has really built a dermatology clinic. And we have provided, through the grant, we've provided electrosurgery, some hypercators, have provided cryosurgery, phototherapy, laser therapy, dermabrasion equipment, and are providing some for both the hospital and for the community this clinic access for dermatology. So I think it's similar to what you all have been doing in orthopedics as far as increasing the primary care physician capacity.
Mm-hmm. Thank you, Doctor. And thank you for your participation today.
This is Joe with Santa Clara County. A comment and then just kind of also a heads up.
Okay.
We hold similar sessions. We call them luncheon with a specialist. And over the last year, we have held 3 of these luncheons in areas that we've been working on, including neurology, ophthalmology, and orthopedics. And we hold these sessions during our consortia peer meeting. So we have the specialists come directly to the medical director's meeting and spend an hour and just beginning to impart knowledge about a proper referral to the certain specialty area. But we've also noticed that it helps reduce the isolation between the primary care provider and the specialist, and it begins that natural communication between these two parties. One of the things, and we have just recently received our certification to provide CME, and I was not in on that process, but one of the things we recognize moving forward is in order for you to be able to provide CMEs, the majority of your audience has to be physicians. So that's something we discovered. So I just throw that out. I mean, you can do it. You can also provide, continuing education for RNs and other medical professionals, but to provide CMEs to a physician, the gathering, the number of people in the group, the majority have to be physicians to offer CMEs.
Okay, that's a good point to consider.
Because oftentimes we do this around a QI group, and there's a variety of different medical professionals and providers in the meeting.
I see. Kim, did you find that for your particular program?
Pardon?
I was just, thank you, Joe, for sharing that. I was just asking Kim if she found that to be so for her particular CME program.
Yes, and yes, we have. And as the credits are still pending, we're waiting to find out because our group has physicians and RNs and PAs all that come because they want to learn the topic whether they're going to get the credits anyway. But we are waiting to find out how many of the non-physicians will end up getting the CME credits.
I see. So you opened it up to other medical professionals as well.
So to all of the primary care providers, the mid-levels and the physicians.
That's great. Okay. Any other comments or questions? All right. Let's move on to our next question. So I think you've touched on this, Kim. You talked a lot about what's gone well, and you talked a little bit about the challenges. Other than the technical issues that you have with teleconferencing, were there any other types of challenges that you have found?
Actually, I think our greatest challenge was the technical issues. Everything else has gone surprisingly well. I mean, we've been pleasantly surprised with the quality of the presentations, the turnout to the presentations, and even the CME credits. We didn't know how we were going to go into that when we applied for the grant, and that just kind of worked itself out with the partnership with the hospital.
Terrific. Okay, anyone else have any challenges that they've encountered along the way? I know you just mentioned something, Joe, about having to have the majority of people be physicians. Any other comments? I know, Dr. Chandler, you've had some grand rounds. Do you have anything you'd like to share?
Well, our experience has been very similar to the one just presented. We get CMEs, we invite all the physicians from the coalition. They've been very successful. So I don't know that I have too much to add unless people have questions.
Okay. All right. Any other questions or comments? Okay.
I have a quick question. In doing some research and starting our specialty training sessions, one of the things I was wondering is, do you do more of a observational grand rounds type of approach or a didactic where it's basically lecture discussion and so forth?
So with orthopedics, we've done more of the didactic and then, question answer at the end. We're going into pain management for our second year, and that will be more of a grand rounds type of CME session where the physicians have been invited to bring their most difficult pain management cases and to discuss those in 2-hour sessions with the UC Davis pain specialist.
This is Dr. Chandler. We've done OBGYN, and we told the specialists really to try to make it interactive. And since our audience is about, 30 providers, it can be very personal and interactive when they talk about cases. We just did a cardiology talk on adult congenital heart disease, and that was pretty interactive. Probably not as much as GYN, and it may be the different topics which people see more volume of that they get really interactive with the speaker. But we've really tried to make it that way if possible. I was just wondering, has anyone else out there tried the shadowing approach? Because our dermatologist is interested in doing that. However, in moving forward, we found that it would have to be very limited because the county feels that more than 2 shadowing at a time would be a little intrusive to the patient. So we're wondering if we just set 2 at a time for 2 hours and then have 2 more come in, wondering if anyone else has experienced that.
This is Amy from Teacher of the Safety Net Yellow County, and we're doing shadowing, but we're doing it one-on-one. So we're doing a provider and a specialist in the office. Our provider goes over to the specialist's office for about 4 hours. We try and schedule one of our provider's referrals during that time so that he can actually see his own patient as well, which is helpful because they know a little bit more about the case. Our biggest challenge right now is just really figuring out what we want the providers to come back with and having some concrete things that you went and shadowed this patient and now you can do this in primary care, not, oh yeah, I learned a lot more about orthopedics. And didn't really improve their referrals or anything like that. So we're really trying to set some goals and curriculum and really develop some specific things that we hope to get out of our expanded scope of practice. So that's really held us up a little bit and trying to figure out how to do that and, what exactly that looks like.
Okay, great. Thanks.
You've raised your
Dr. Chandler, we're doing the same thing. We're writing curriculum with these specialists, and we're doing one-on-one for 4 hours. I think we toyed with the topic of actually getting CME for the time, but I'm not sure if that's possible or for part of the time.
Great. I think you raised a really good important point, Amy, regarding the competency and the scope of our primary care providers and evaluating how they're doing and how you do that ongoing evaluation. Who's working with you on that?
It's all me. I met with our medical director and our assistant medical director, and we come up with a list of some skills and who should do it and who shouldn't. And we really want to leave it up to the provider, but before you go and spend 4 hours in a specialist's office, I want you to tell me what you're interested in and what you're hoping to come out of it with. And when you come out, tell me what the next steps are. But then on that level, it makes some work for our provider because they're going to have to, almost write a report on their fellowship, and they're not thrilled with having to do that.
Yeah, one more job.
Exactly. So they'd rather, at that point, well, I'd rather just see my own patients. So.
Were there issues identified prior to them actually shadowing them, which is why they are shadowing them anyway, that could then just be measured?
No, there wasn't. It's just, in general, we'd like to increase our orthopedic scope of practice or our rheumatology scope of practice. And so we don't have any specific skills that we've identified.
Well, continuing work in progress.
Definitely.
Okay. Well, Kim, why don't you tell us, I think you've mentioned a little bit, what are your next steps or your plans for increasing your primary care provider capacity? I know you've mentioned pain management. Can you give us a bit more detail on what your strategies are going to be?
Yeah, so with pain management, like I had said earlier in the call, we have no access really to pain management in the county with only one provider and him very resistant to reaching the safety net population.
Mm-hmm.
So we knew it was a need. We didn't really know how we were going to go forward with it. But what we have learned over and over is the key to success is relationships. And on our provider capacity group, we have a very well-respected retired neurologist who had worked in Sacramento, who our primary care providers in our county know well because they had referred to him. And when we expanded to include specialty care, we asked him to sit on our provider capacity group, which he did very graciously. And as he listened to us talk about our issues with pain management, he said, I sit on a board with UC Davis, Scott Fishman with pain management, and let me just talk to him about Excel and your track record with all of your care pathways and that you want to go into pain management. So he spoke with him, and he said, this is, as long as the bottom line works out for us, we're very interested. This is the kind of thing we like to do. So we had a meeting with them, and right now we're in the planning phases of developing a care pathway for pain management so that our primary care providers have access to a telehealth consult with UC Davis. But part of that, too, is in trying to increase the capacity of the primary care provider is they need to know how to treat these patients better on their own. And so they'll be doing, probably starting this summer or fall, 2-hour grand round type sessions where the doctors have been invited to bring their most difficult pain management cases to discuss and learn how to handle these cases. And they've also offered, once we go forward with our contracting, to just be available for consults if there is any kind of difficult case with the primary care provider. Because actually UC Davis Pain Management really also wants to increase the capacity of the primary care provider. So it was a good merging of similar goals.
Great. Okay, let's move on. So now it's your turn, Kim. Is there a question that you'd like to ask your specialty care colleagues on the line with us today that hasn't already been raised?
Well, I was going to say, my question really was, aside from CMEs, how are these different coalitions working on improving access or improving the primary care providers' capacity? And some of that has already come out, but are there others out there that are doing some different ideas for that, implementing different ideas?
Anyone?
I it again. So what I heard was different approaches as far as CME sessions, separate sessions, lunch and round tables that may be CME or CEUs or other credits if they're offered. What I was fascinated by was Kim's comment back about your providers were interested in attending regardless of whether they got credits or not. That you're still working on getting their credit. What I was fascinated with Joe's response as far as building that relationship and taking away some of the isolation that PCPs and specialists sometimes feel, that the Grand Canyon between them.
Mm-hmm.
There's the shadowing approach, the grand rounds, and the structured CMEs. Did I miss anything as far as other coalitions that are doing other creative approaches to it?
Hi,
This is Kieran from San Francisco.
Hi, Kieran.
So what I wanted to add about our coalition is that we're focusing on 3 different specialty areas, GI, endocrine, and pulmonary. And what our coalition is doing is developing and improving guidelines for basically one sort of high referral disease in each of those 3 specialty areas. And what our physicians will be doing, how they'll be getting that information out to the primary care providers, is through our Safety Net's e-referral system, which all of the Safety Net providers within the city and county of San Francisco are using.
So and it's interesting, Kieran, that you say that because a lot of the coalitions across the state and across this initiative, there is that close tie between their engagement and work on establishing guidelines, that cluster group, and today's cluster group discussion about increasing provider capacity. So San Francisco spends a good deal of time building the guidelines. Now, distribution of that going through the e-referral system?
Yeah, so when primary care docs basically get onto our e-referral system, each specialty area has sort of an education and referral guidelines page, that the primary care doctors must take a look at before they actually submit a referral to that specialty. So we're developing better guidelines as well as some patient education material.
Great. I know, Kim, you mentioned that your care pathways, you're folding in your guidelines, correct?
Right. So our referral process has the guidelines embedded in it, and if the referral doesn't meet the guidelines for orthopedics, like the correct imaging and the Medi-Cal card and the history, then the referral is denied and returned back to the primary care provider. But a note is written why it's denied, and the whole goal is to help the primary care provider send good referrals that will be accepted, and they're allowed to send the referral again with the appropriate background or guidelines that are necessary. And when that's accepted, then the patients are scheduled, and the primary care provider then gets the reports on the patient.
Kim, how does that note get back to them?
Depends on where it is in the process. It's often faxed back to the referral specialist at the primary care provider site. And in some sites, the orthopedic office has secure email so that it's emailed if there's a secure line. So it's scanned in. Right now, the referral is it's a paper process. And but at the orthopedic office, they'll scan it in and then email it back to the primary care providers.
I know my colleagues here in LA County are certainly challenged by bidirectional information and clean information about why referrals may be denied.
And that actually has been a huge thing, even for the orthopedist to actually say why it's denied. And I do think that increases the primary care provider's capacity if they understand, this is denied because a different specialist should be seeing this, or this should go to PT before I see this, and then you can refer it. It's like was mentioned earlier, the communication that is opened up has really allowed for a lot of learning to go on between the specialists and the primary care providers.
Sarah, and forgive me, I'm not going to single out any one of the coalitions. There's also several of the coalitions that are having conversations about how do you provide additional education for the referral coordinators that support these primary care providers, for them to learn better about, no, Dr. Smith, I don't have all the paperwork to submit this as a complete referral, or et cetera. Has that entered into your work yet, Kim?
Yeah, actually, I left that out. But before we created our referral tool, we went to each office and interviewed the referral specialists, and then put together best practices of what we saw worked well and didn't work so well. But we really tried to make it no pointing fingers that your office is really unorganized and you guys have it. Well, we just brought them together then, went over best practices, and we had a big dinner where we had the providers and some of the office staff and the referral specialists brainstorm what we needed to go forward with the specialty care initiative. And out of that came some really good protocols for just handling this, handing back and forth paper, as well as, the medical needs of what's required from the medical perspective for a good referral. So our referral tool, if you look at it, has the medical requirements. It also has, fax numbers and patient made it to the appointment, didn't make it to the appointment, and then some data elements that we wanted so that we could report back.
Great. How many were in that group that you met with?
Probably about 25. We're a rural county. We kind of had representatives from different groups. And then once we had our referral tool almost ready to send out, we brought in all of the referral specialists again, and I had a lunch with them, and we went over it, and I explained it to them. And they kind of put the finishing touches on, well, this would work better in our offices. And they enjoyed it because they all looked around at each other and said, oh, you're the one I've been sending these to. You're the one I'm getting it back from. Okay, if that works for you, then we'll do this. And then I spent a lot of time in the offices where the actual referrals went back and forth to helping them create business rules on how to handle it well. But it went really well because they knew that their providers had said, this is what we're going to do. Mm-hmm. So that support went down, and yet they felt involved in the creation of the tool.
Absolutely. Very important people in the process who not often have a chance to come together. I know we've heard that a lot with other groups that have brought their referral groups together, people together, and have put the names and faces together. And again, it's pointed to that relationship building and open communication. Mm-hmm. That seems to really make the difference. Okay, let's see. I think, are there any other questions or last comments for Kim?
This is Sarah from the Community Clinic Consortium again. I had one question in general.
Yeah.
Have people had more success working with hospitals or recruiting private physicians to do these for the specialists?
To do the CME sessions, you mean?
Yeah. Or the shadowing.
Oh, for shadowing.
No, for CME or shadowing, just in general, getting specialists on board. Have people found that it's that private physicians are sort of easier to get to than working through the hospital systems, or do the hospital systems tend to open up more opportunities?
I think Excel has found both. The orthopedic group that we're working with is a private group. That's so it's not a hospital group, but for them, the selling point was it was getting their faces and their names out. They were getting a lot of accolades with the primary care providers for opening up access to orthopedics, to the point that their comments were after they had done sub-meet and greet, my goodness, we had no idea the primary care providers liked this so much. I guess we can't quit now. So that was really encouraging to us. But on the other hand, we found with our primary care providers, the individual practices out there are barely making overhead, but the primary care providers that are part of a hospital system and kind of a practice is set up under the hospital, they're salaried, and they don't feel the financial pressures as much, and so they feel more able and free to participate.
Great, thank you.
Anybody else have experience with that they'd want to share with Sarah?
Okay, well, if there are no other questions or comments, our last slide just gives you the contact information for Kim. I've added Sandra Dunn, who is the project manager, who has, I think you mentioned, is on sabbatical. Is that right, Kim?
That's right. She'll be
back
next month.
Next month. So either Sandra or Kim would be happy to answer any further questions that you may have through email or telephone number. And our topic for next week will focus on integrating care coordination And is there anyone who would like to volunteer? Or would like to volunteer anyone for next week's presentation? Does everyone still enjoy this interview format? Any comments or thoughts about that?
Hearing no objections, we're going to continue this format.
Was that someone?
This is Joni. I think it works well.
Great. Thank you, Joni.
For next month's increasing primary care capacity discussion, is there a preference on topics from the group? What would you like for us to set up for you? Oh, we've caught everyone on those sugar lows since the
I have a question. I want to thank those people who I reached out to before we did our first specialty training, because I called a couple of the other coalitions, so thank you for your help. But I was wondering, those of you that have conducted a survey of primary care physicians to see what they would like specialty education to look like, is there any way anyone could share a survey that they've completed around a specific specialty? Because it's something that we've talked about, the neurologists that are going to do our next neurology referral guideline specialty training in April thought they would like for a survey to go out prior. So just wondering if anyone's done that.
So any sample surveys for PCPs about desired curriculum for a CME session?
Yeah.
Okay. We'll put that out to the listserv as well, to the entire
Thanks.
Yeah.
as well, but that's Joni Novosel, correct?
Yep, that's me asking for help.
Great.
Thank you.
Good journey.
Any input or feedback specific to the topic of increasing primary care capacity for our discussion next month? Please go ahead and forward to Louisa.
And again, please, if you can, fill out the brief survey after today's webinar, just to continue getting your feedback and thoughts that you may have after this call on ways that we can continue improving our sessions. And you can either email or call if you don't do the survey. But I want to thank you all for your participation, especially Kim. Thank you so much, Kim, for sharing your best practices and learning and taking the time to be with us today.
My pleasure.
And we look forward to having you all join us again next Tuesday, March 23rd, for Integrating Care Coordination. Thank you all. Goodbye.
Bye.
Thank you.